Dr. Muhannad Amasha from University of Manchester, and he practiced here as well in View Clinic. He's very talented, skilled, and he is already giving his experience and all his knowledge, very good tricks and tips in this topic. Um, so I'll leave you now with our speaker. And please, if you have any question, please type it in the Q&A button down here, or wherever you can see it, the Q&A button, and not in the chat, please. And if you like by the presentation of the webinar, and you feel that your question has been answered, so would you please remove it, so we'll not take time of the questions with it. Okay, so thank you all, and I'll leave you now with Dr. Muhammad.
Yes, hello everyone. So we will start today with our last part of the series, which will focus on after receiving the veneers from the lab and the delivery of the veneer. That means bonding. So in the first part, I'm just going to refresh your memory. We talked about case assessment. How do you choose your cases? How do you approach the treatment planning, and how do you do smile designing and waxing and all that good stuff. In the part 2, we talked about preparing the tooth according to your plan and taking the impression, which is a very important topic. And today we will talk about cementation and assessment. So the outline today will focus on 3 main topics, which is assessing the veneers from a biofunctional standpoint, how to make sure that your veneers will be accepted by the gingiva and the periodontal and the patient in general. The second part, we will be assessing the aesthetics. How do you judge a veneer, a good veneer or a bad veneer or a bad smile, aesthetic wise. And the last part, we will talk about bonding. So let's talk about the first part. One of the first things when you get the veneer you want to check is the fit of your veneer. So how do you do that? You clean your temporary and clean your tooth, remove everything, and put your single veneer in place. Check if it's rocking or is there any interference, and clean. If any interference, you can clean it, remove it. That's good. And if it's there's something wrong with the fitting, of course, you might anticipate that you might have to have a problem here. Next, we will check the contacts. How do we check the contact? By placing all the veneers and checking the contact with visual inspection. If some veneers are pushing the neighboring ones, so let's, an example, I'm putting this central and it's pushing away the other central, that might mean you have a tight spot between them. And you might want to identify the tight spot between the veneers by using any material like articulating paper, and identify it and reduce it. Of course, you can send it back to your lab as well. One of the most important aspects in veneers and crowns in general is your marginal integrity. How well does your veneer fit on the margin of the tooth? So a marginal integrity is very important. We have 3 common margin errors. First one is when you place your explorer on the tooth and raise it up and it will catch the veneer. That means we have an overhang. The other also common problem is when you have a space between your veneer and your tooth, and that will be visualized with your eyes, and especially if you have if you're using magnification. The third part is when you have a ledge. The ledge is an error that you have in the margin when your ceramic veneer is not thick enough. And this one is not very common, I see the overhangs and the open margins more often. And if you want to see the ledge, how do you diagnose it? You diagnose it in the opposite direction of the overhang. So you go from your veneer and go towards your tooth, and you will find a catch. A slight catch for the overhang or the ledge is to be expected. Sometimes you can just ignore it or just clean it. But if it's something that is causing your explorer to stop, you want to correct that problem. And here is an example of a couple of months old veneers on the left side of this picture. And you can see the bleeding in the gingiva, and you can see the, the bad marginal integrity, bad marginal adaptation is causing this severe inflammation. And this is a couple of weeks after we changed the existing veneers, and you can see that the gingiva immediately healed. Another problem is when you try your veneer and you find this open margin. This is an open margin that I found in one of my cases, and you can send it back to the lab. He will add some marginal ceramic, or he will redo the whole thing. When you are checking your margins and you find an open margin, just before you send it back to the lab or something like that, just check that you have a good fitting, check the other sides of your ceramic veneer, because sometimes it's not fully seated or you have an interference somewhere in the distal or somewhere in the incisal. So make sure you have a complete seating before you judge the case. Ideally, you want to have a marginal adaptation like this one after cementation or bonding. And this marginal adaptation, you will see after bonding here, it basically disappeared. And this is such a nice thing to see. And of course, your ceramic veneer will have better marginal adaptation after you cement it and you polish this area. Why? Because the cement will fill any small micro gaps, the resin cement. One of the other things you want to check is the occlusion. The buccal side of your tooth typically doesn't have an occlusion with the mandible, because the upper teeth are always buccally placed, positioned in relation to the mandible. So that means that's good news, because you do not have to spend a lot of time checking your static occlusion if the occlusion is normal. But you might want to check the dynamic occlusion, the guidance. Is it a canine guidance or a group function? And you want to make sure that you didn't change this dynamic occlusion too much for the patient. So it's a predictable thing to bond upper veneers. Lower veneers, you might have to spend more time to check that you didn't cause any interferences. And after bonding of the veneers, it's easier to identify small occlusal discrepancies and correct them, okay? So this is the occlusion thing. And please remember that if you run into a problem in mouth, always check the problem on the cast. And that means check it on the control model, which is a cast that is not separated or appendixed. And if you do that, you will have a better idea of identifying the cause of the problem. If the problem originated from your, if you can find the problem on the cast, that means the problem is caused by the lab technician, and he didn't take a good procedures in the previous steps. If you cannot replicate the problem on the cast, for example, if you didn't see an open margin here, that means you might have a problem on your cast, and you cannot blame your lab technician too much, because maybe the impression was not good, or it was distorted, or any other problems. So make sure you double check both sides of the story. The aesthetic assessment, let's talk about aesthetic assessment now. I will talk about 9 factors how to check your veneers for aesthetic assessment. The ninth factor is appearance from a distance. First thing, you want to place your veneers and check them from a distance. Why do I want you to check them from a distance? Because I don't want you to analyze each tooth alone, and that happens when you are too close to your teeth. So when you are away, like an arm distance from your patient, and you want them to talk and smile and see how the tooth, how the whole teeth look in relation to the face and the mouth. A lot of times when we are checking, we see the teeth are too big in relation to the mouth. And that's when we make some adjustments and make them smaller, as you can see here in the second photo. So that's something you can see only when you are assessing the whole thing. Don't analyze the smile tooth by tooth just yet. The eighth factor you want to check is canting and midline. This here is an example of a canted veneer. You can see that the right side is longer, the left side is short, and the whole thing is canted, and the midline is canted. And that means the lab technician didn't have either he didn't have enough information to do the case correctly, or he didn't pay attention to the pictures and the preparation and everything before. So in this case, you have to send it back because this is a very noticeable canting. Number 7, protrusion. You want to look at your patients from the side, and you might want to even take a picture and show it to the patient because they cannot see their full profile. You just want to make sure that your teeth are well within the constraints of the mouth and they are not going outside of the natural limits. Some patients want a more visible teeth. Some patients want a more invisible teeth. So that's something you want to check when you are putting your veneers before you bond them. In this nice case that I posted last week, we got the privilege of reducing the protrusion on the patient and restoring the normal harmony of the natural smile. And of course, in the treatment planning with your patient, you want to pinpoint their concern in order to fix it. Believe it or not, in this patient, the patient was not complaining from the color. She was not complaining even from anything in the smile, even the open bite, she wasn't complaining from it. She just wants to close this gap and to reduce the protrusion. Number 6, the shade. After you place your veneers or the crowns, you want to check if there's any gray tooth among the natural teeth or the natural veneers. If all your veneers are normal in shade and one of them is gray, it will kind of ruin the whole thing. So you might want to make sure to communicate that with your lab technicians so he can mask the discoloration effectively, and you want to give him a thick enough preparation. In this case, you can see the metal post. I was not able to remove it because it will really destroy the tooth, and the metal post is in place and the whole tooth is good. The root canal was good, so I didn't want to play with the tooth too much. I just wanted to redo the smile, and we did a good job by using a highly opacious core. Number 5, vitality of the ceramic. So you want to assess the translucency on the incisal edge. You want to check that you're giving the patient what he wants. You want to make sure your veneer looks close to the natural teeth. And you can see how the different finishing of those two different cases gives you different appearance. You can see here how it looks kind of more natural, and here it doesn't look as natural because it doesn't have the same amount of vitality. You want to make sure that the layers of the ceramic are placed correctly. Sometimes it's too opaque, sometimes it's too translucent. Number 4, special characteristics. You want to check your teeth for any special characteristics like the opalescence in the incisal edge, those mamelons effects, any halo effect on the centrals or the laterals. And I want to make sure, always to make sure, that my lab technician didn't give me just a nice characterization and opalescent effect on the 4 anterior teeth or even the 6 anterior teeth, while neglecting the premolars, because neglecting the premolars gives you a discrepancy that is not very aesthetic. So make sure to always give the premolars the same amount of care. Of course, it doesn't have the same characteristics and translucency as the centrals and laterals, but nevertheless, it has to have the same spirit of the whole smile. And when we are doing just 2 teeth among the whole natural dentition, in this case, it's very difficult to copy the natural dentition, because the natural teeth has a lot of special characteristics. And here you can see the old crown, it doesn't really match the rest of the teeth. And we replaced it with a more natural smile, a more natural crown, and the patient was much, much more happier with his new smile, even though it doesn't have the same white appearance. This one has a white appearance, but he was much more happier with an integrated crown nonetheless. And they didn't want to do anything about the shade of these teeth. Number 3, shape. This is a very, very important. Here where you want to have a very skilled lab technician. Check the morphology, and here you want to close in on the teeth. Even you want to use your magnification, no problem. Just make sure you have, this is before and this is after. And you can see that this central is not very successful in morphological assessment. It doesn't have a nice width to length ratio. And this lateral doesn't have asymmetrical mesial and distal line angles. So we were able to fix that with a natural curve of the teeth, with the line angles falling as it should be, and the cervical bulge of the incisals and the whole teeth. So this is something you want to check. Sometimes you have a very nice smile, but one morphology of one of the teeth is not correct. So you might want to fix that if it's not optimum. Number 2 is the texture. So after you assessed your morphology, you want to check your texture. There's 2 kinds of texture. There's micro and macro texture. Of course, micro texture is the small pericymata, we call them, the enamel surface. This decreases with age, and with aged patients, you see the surface of the enamel to be smooth. And the macro texture is the dentinal loops and the whole shape of the tooth. So check those 2 things, and make sure you don't overdo your texture if you're doing, if you want to achieve an integrated crown. This case, we did only 1 crown here, and we wanted to achieve integrated crowns, so we didn't overdo the texture because we wanted to follow the natural dentition, and you can see how it looks almost the same. Number 1 and the last point is the pink aesthetics. What is pink aesthetics? It means the gingiva. In this case, I have a missing lateral and an old bridge, and this is something you want to consider at the start of your treatment planning and the preparation phase, because it's too late to fix anything now. So it's just now in this session, in this appointment with your patient, you're just checking the results of what you planned for. So in the case of this gingiva, I placed a temporary cantilever crown on this canine to push the gingiva up and shape it the way I wanted. And of course, you can do some gingivectomy to have a better aesthetics. And here we have the final crown, final bridge, which will push my gingiva into place. And I want to check, in this case, I want to check any supragingival margins. Because in case of your preparation, if you didn't prepare very well subgingival, as I told you, zero point 0.5 subgingival, if you didn't go enough apically, you might see that your veneers margin is visible, and that's not a pleasing thing to see. So this is after we placed the bridge, and you can see we closed everything and it looks totally natural. One more thing you want to assess in this pink aesthetic phase is that you don't have any black triangle that are too big. Because if you have two big black triangles, you might want to send back the case to your lab technician and fill in the gaps to close them with ceramic. Or you even might want to consider re-preparing your teeth to include this area, okay? That's everything for the aesthetic assessment. Let's talk about bonding those veneers. First of all, the sequencing of your veneers cementation has to start with your two centrals here. You want to bond your two centrals first and make sure they are aligned and they are symmetric and the way they should be. Because if you started wrong with your centrals, all of your bonding for the laterals, the canines and the premolars will be pushed somehow, and you will have a butterfly effect of having too many problems colliding over each other, and you will not have a successful bonding. So I start with two centrals, and then I go distally. I can bond two laterals after that, and then two canines, and then two premolars. But what I like to do is after the two centrals are bonded, I like to take my time one tooth at a time. I etch, bond the lateral, and go to the next side, go here, go here. That's the way I like to do it, but it's up to you. So let's talk about ceramic surface preparation. And we will talk first about the glass ceramic, because the glass ceramics is the most popular kind of ceramics that we use for veneers or for crowns. And that includes the feldspathic, which are highly beautiful ceramics, but they are less strong, so they are weaker. And then we have the lithium disilicate, which is the most popular, which is also known as Emax. And then we have the lucite reinforced, which is less popular, which is also called the Impress. So most of the cases are lithium disilicate, and we have a lot of cases with feldspathic as well. And after we talk about preparing these surfaces, we will brush quickly on the zirconia, but it's not the topic of today. So you want to check your veneers. In this case, those are partial veneers, which means they are feldspathic. So you want to make sure they are clean and they are free from glue or wax or anything that your lab technician left behind and didn't clean for you. Because if you put your acid etching here and if the surface is not clean, you basically didn't etch it. And so in this case, we have a very tiny veneer, partial veneer. So we place hydrofluoric acid for 20 seconds. I like to use some kind of time management. So I like to check my watch, put my acid etch, and if I'm training my as a nurse to do it, I have to make sure she knows what she's doing for the first couple of times before I let her do it on her own. And then we can, I really like to etch one tooth at a time or two teeth at a time, because you cannot etch 6 or 8 or 10 teeth at the same time while making sure you have 20 seconds of etching on each tooth. It's not possible. So after we etched the tooth with hydrofluoric acid, we apply silane on the tooth for 1 minute on the internal surfaces of the tooth. 1 minute, we wait, and then we do a strong air blast to remove everything, okay? And this means your veneer, whether it's Emax or feldspathic, this means it's ready to be bonded. As for zirconia, do we do acid etching with hydrofluoric acid and silane for zirconia? Of course not. What do we do for zirconia is we replace the etching with sandblasting, and we replace the silane with MDP, okay? So I want you to take a photo or screenshot of this slide, because this is what you want to, how you want to deal with your zirconia. The sandblast will be aluminum oxide. Pressure is 2.8 bars. Angulation is 60. Distance is 1 to 2 centimeters. Time is 20 seconds. And the particle size is 30 to 50. 30 is better, but don't go above 50, because bigger particles like 20 to 50 microns will damage your zirconia and will cause a crack. Tooth surface preparation. Now that we're done with preparing our veneers, we will prepare our teeth. And this is where it gets interesting, because I know some of you are interested in learning how to bond under rubber dam. Isolating the teeth, first of all, you want to control the saliva. And in my experience, this is easy. Controlling saliva is easy. What's the real challenge is controlling the bleeding from the gingiva. This is really challenging, especially if you have a bad oral hygiene. You can use retraction cord, you can use anything to control the bleeding, but you cannot really overcome a bad bleeding gingiva, because this is something you have to tell the patient, please take care of your teeth in the next 1 week, 2 weeks while we make your veneers for you. So when we start cementing, you will have a nice bonding strength. In this case, you can see these are zirconia veneers, and this is after a couple of months from cementing them. And this is not my case, but you can see the premolar, the canine, the central are all debonded. That's a huge failure rate. That's 50% failure. And at first, I have to be honest with you, I judged the dentist a little bit for doing this case, but after dealing with the patient and see how poorly he maintains his teeth and how impatient he is with the dental procedures, I was more forgiving of the dentist after that. But anyway, I just want to make sure that the oral hygiene point sticks. Rubber dam. Why do I use rubber dam for bonding my veneers? So first of all, I want to retract the soft tissue. Why? Because it gives me a great visualization of my bonding surface. And in this case of partial veneers, it would not be possible to do it under normal circumstances, because the rubber dam would not, if I didn't put rubber dam to retract this gingiva here, how can I passively place my veneers on the teeth? So it gives me complete visualization of the rubber, of the bonding area. So that means I have better seating of my prosthesis. The second point it provides better isolation, because no matter how good you can isolate the tooth there's nothing compared, this is nothing compared to achieving an apical seal, and you see this nice isolation of the tooth. And a bonus point is that you can sandblast your tooth so you can really clean it without causing any bleeding for the gingiva. So you can argue that it has a better bonding strength. And for me, when I do veneers, I want them to last for years, uh, many, many years. So that's why we do everything in our power to give the patient the least amount of trouble. Um, so this is why I like to do it under rubber dam. And one more thing, in this, we're living in a pandemic and COVID-19 is found in the saliva. So when you're doing any dental procedures, the MOH everywhere is suggesting that using the rubber dam is mandatory now because it will control the flow, the spreading of the aerosols in the air. So that's another good point in these times to use rubber dam. But I'm not saying it's the only way to cement or bond your veneers. I'm just trying to tell you about it so you can learn the possibilities. What are the drawbacks of the rubber dam? Let's talk about the drawbacks. First of all, it is challenging and it demands a learning curve from the dentist. You have to know how to achieve proper isolation, proper tissue retraction, and this is a different topic. Maybe we will talk about it in the future, how to like advanced rubber dam skills or something like that. But if you learn it, it will save you time because you will not have any mid procedure problems like I'm doing this 4 teeth now and one of them starts bleeding after acid etching, so I have to dry it and bond it and really quickly work. It gives you peace of mind and it makes the whole procedure much more predictable. So yes, it takes more time from you at the beginning, but after you master it, it will give you peace of mind, better isolation, better seating, and more predictable procedure. It typically takes about 1.5 hours to 2 hours to bond 10 teeth. But I know after that, that there is zero problems with the bonding procedure. Of course, after you put your rubber dam in such way, you cannot check your occlusion anymore. So you want to check the occlusion before you put your rubber dam because you cannot remove the rubber dam or ask the patient to bite on these metals. So it's too late. You put the rubber dam, you already know if your occlusion is good or not before that. And when you do a subgingival preparation, it's more challenging to achieve such retraction. So ideally, it's good for equigingival preparations and more challenging to do. It's not impossible, it's more challenging to do for subgingival preparations. But you want to decide for yourself, is it worth it to bond under these beautiful teeth or just bond with the saliva, with the non-rubber dam applied teeth? This is another technique you can use is split dam. It will remove everything from your way and will let you focus on your teeth. And of course, you can use the cheek retractors as well. But the split dam doesn't retract the teeth individually. So I really don't see much benefit from using a split dam compared to the normal cheek retractors. But you know, it's there. It's an option. So after we place the rubber dam, I like to use those tissue retractor clamps, which are called Brinker tissue retractor clamps. The old way of cleaning the tooth is brush and pumice. And the new way of cleaning the tooth is using the sandblaster, using aluminum oxide particles 27 to 50 microns under 2.8 bars or 50 pounds per square inch. Also, I want you to take a screenshot or a photo of this slide. because this is when you decide to buy a sandblaster, and I really urge everybody to buy a sandblaster, or at the very least buy those ProfiJet from NSK uh, to clean their teeth better, because this if you apply your acid etch on your tooth before cleaning it, you didn't really etch the tooth. Okay, think about that, because your acid etch does not clean the tooth. You have to clean it before that. The next step is isolating the proximal surfaces, which means I like to put Teflon on one of the teeth. In this case, I didn't put Teflon because this one is a crown that we already bonded. So you cannot really etch the ceramic with acid etch, with a phosphoric acid etch. So there's no need to protect this surface. Just protect your teeth, the enamel or the dentine material. You can use celluloid strips, but I like to use Teflon more. After that, you can use the phosphoric acid etch, 15 seconds on the enamel, 30 seconds, 15 seconds on the dentine, 30 seconds on the enamel. If you're doing selective etch or something like that, you can start by putting your gel, the acid etch, on the enamel margins and wait 15 seconds, and then start after this 15 seconds and apply it on the dentine for another 15 seconds, and then wash everything. This means you effectively etched the enamel for 30 seconds and you etched the dentine for 15 seconds. And that's why you have to use a consistency of your acid etch that is a little bit viscous, so it stays in its place and doesn't go everywhere. So you want to put it on the enamel, and so it doesn't stretch out and go to your dentine. And this is the most out of focus photo I have ever taken, but I didn't find another photo, so I had to use it. After that, the bonding is you place your bond. Take your time with the bonding. After you place it on everywhere on your tooth surface, don't just go rush it everywhere. Take your time. Make sure every surface has the bonding material on it. And then you gently air blast the surface to avoid any pooling of your bonding. And then you light cure the tooth surface. And this is here where you have as a ready to bond surface. After that comes, so now we have we have prepared our ceramic and we have prepared our teeth. So not our teeth, our tooth, because I do them one step at a time. So choose the cement. Choosing the cement is important when you have um, a highly translucent veneer, okay? So if you have a highly translucent veneer and you use with it a highly translucent cement, and you have a good stump shade, which means the shade of your tooth is acceptable, it's not very dark, so you will get the best visual properties because the light will be able to penetrate your veneer and will go through the translucent cement and will reflect very nicely and visually beautiful on the eye. Um, so this is where you want to use a good translucent veneer. Otherwise, if you have a stump shade that is dark, or you are using an opacious veneer core, your cement will not matter as much because you cannot really see the cement under the opacious core of your veneer, okay? So choosing the cement, there's two kinds of cases. You have crowns and you have veneers. For veneers, you want to use the light cured resin cement. And for the crowns, you want to be able to double cure the cement because your light curing might not reach beyond the crown surface. So This is where the selection happens. Uh, as for Dentsply, they have Calibra Ceram, which is a dual cure and also light cure product. And they have Calibra Veneer, which is only light cure product. So if you can light cure the cement through the veneer, that's nice. You can use the Calibra veneer, the light cured option, and you have endless time to work on your veneer. But if you're working with a crown with limited access to your light through your light curing cannot penetrate through the crown, you want to be able to use a dual curing option. Okay. And in both cases, you want to make sure your cement doesn't have any amine in it, because the amine is found to change color and it's not color stable. So the cement has to have color stability. And of course, the first couple of seconds, you tack cure the cement and it will light cure, but without hardening the cement too much. And we call that the gel phase. And the nice thing about those two products, the Calibra, is they have an extended gel phase, which makes removing the excess very nice. I like to use a blade of 12 or a blade of 15 to clean those surfaces here. It will peel off very nicely with the gel phase. And I like to use my floss between the teeth. If it's a veneer, I ask my assistant to hold the veneers in place because they are still not 100% bonded. So I like my assistant to put her finger and stabilize my veneer. Then I will clean with my floss, and then I can see for myself that the veneer has zero excess cement. And ideally, you want to achieve that before going to the next tooth. And this way, zero problems with the excess cement, because you can visualize it completely before removing the rubber dam. After that, you want to cure completely, and you want to cure from different angles, lingually, buccally, slightly mesial, slightly distal, and your light cure unit has to be as close as possible without touching the teeth. And you want to use glycerine here. This is glycerine. The glycerine blocks out the oxygen from the air and makes it possible to cure the outermost layer of the uh, resin, because the resin, if it's in contact with your air, it doesn't cure. The outermost layer doesn't cure. So this is why I like to use glycerine. You can use Vaseline, but Vaseline cannot be washed. So when you go to the next tooth, it's really a problem when your acid etch doesn't work on the tooth because you have Vaseline on it. So only use water soluble, which means glycerine. So now we talked about how to bond one tooth, or in this case, two teeth, the centrals. Next, you will go to the laterals and so on. And that's how you finish your case. And the last thing you want to do is polishing the margins. Why do you need to polish the margins? Because this margin right here is rough, and your gingiva likes to have smooth surfaces next to it, correct? So I really want to stress that you should not use any burrs in this area. High-speed burrs are forbidden. You just want to use Arkansas, which is the white stone on a low handpiece. Uh, Clean here, and then I like to use this option from Dentsply. It's called Enhance, and it's a resin rubber cup. It's very flexible when you put it here, and it goes beyond the margin and makes it very smooth. It's a very nice product to have for this particular use, and you can use it for finishing the composite as well. That means we have done all of the three units we want to talk about, but I want to just recap the procedure one last time so it sticks in your mind. Here is my rubber dam on the two central incisals, okay? And you can see here that my rubber dam is not really applied on the rest of the teeth. This is not a mistake, by the way. This is intentional because I don't want to retract my teeth prematurely, because I don't really need to retract those surfaces just yet. And when I finish from those two teeth, for example, I slightly remove my rubber dam from the sulcus to make the tooth and the gingiva rebound. So this is something you want to think about. So in this case, two centrals, nice preparation. We place the rubber dam, we acid etch, and then we place our bond, which in this case, it's a prime and bond universal from Dentsply. They were generous enough to give me this material to try. And here, the crown was placed, two symmetrical crowns, very nice preparation, very nice symmetry. And then we go back to our sequencing, which means we go to the laterals, protect my surface, acid etch, bond, and everything here. Okay, go to the next tooth, go to the next tooth, put your acid etch right here, protect the surfaces, so, and then bond, and then go to the premolar. And that concludes my lecture today. I hope you found it informative. This is the end. And we are ready for your questions. It took us 50 minutes, 45 minutes. That's a good time.